and good morning. As mentioned, I'm Christina Polyak. I'm a research physician with the Military HIV Research Program, which is a part of the Walter Reed Army Institute of Research. And I'll be talking today about our acute infection data, in specifics, the early capture HIV cohort study. This study was sponsored in part by Walter Reed and MHRP, as well as by the Division of AIDS at NIH. And I'm speaking on behalf of Dr. Merlin Robb, who is our protocol chair and regrets that he can't join us this morning. So the early capture HIV cohort study, or ECHO for short, is better known as RV217. It's a multi-center, non-randomized prospective observational study. The objectives were to characterize recruitment, retention, HIV prevalence, and HIV incidence in high-risk volunteers. We aimed to obtain 150 acute HIV infections, and 30% of these ideally would be captured in phoebic stage 1 and 2. We aimed to characterize host responses and viral dynamics as well. A brief review of the phoebic laboratory staging system. This chart shows days following HIV transmission here, and then plasma viral RNA here. The phoebic stages are listed at the top. So the earliest phase is the eclipse phase, and this occurs, as you can see where the dotted line is, before any detectable viral RNA is present. Then stage 1 occurs when viral RNA turns positive. Stage 2 continues a viral upslope, as well as having a P24 antigen positive. Stage 3 occurs when the ELISA turns positive, and you can first detect HIV antibodies. And then stage 4, 5, and 6 are Western blot becoming intermediate and, indeterminate, then finally becoming positive with a negative P31 antigen, and finally the Western blot turning positive with the positive P31 at the end. We have the time frame for the phoebic stages illustrated here. Viral set point occurs in this region. RV217 aimed to capture people in this box here in phoebic stage 1 and 2. So our sites and methods, we had 4 sites total, 3 in East Africa and 1 in Thailand. We recruited men and women, 18 to 50 years old, of high-risk groups such as female and male sex workers, STI clinic attendees, men who have sex with men, and those who are transgender. We screened them with a CASI, which stands for the Audio Computer Administered Self-Interview, so that we could ask potentially sensitive questions about behaviors related to exchanging goods for sex, unprotected sex with people who have HIV, or having greater 3 or more partners unprotected sex, and reporting an STI symptom. If they screened in with a CASI and or HIV negative, they were offered enrollment into the study. We did enroll a few HIV positives as control and masking group. Our study design is listed here. Phase 1 was surveillance. The goal of this phase was to diagnose HIV infection prior to the advent of detectable antibody. We used small blood volumes, which we'll from now on abbreviate SPVs. And these were done twice weekly with finger sticks of just 600 microliters every 12 months. So patients did come to clinic twice a week for the first 12 months and then monthly for the next 12 months. We did qualitative HIV RNA in real time using the Aptima. Phase 1B, we abbreviated the stutter phase, which patients entered if they were Aptima reactive. This phase included twice weekly blood collections of 30 to 90 milliliters for 1 month. This phase either confirmed diagnosis and then patients entered phase 2, or it established a false positive result, in which case they were returned to phase 1. Phase 2 was following participants with established HIV infection for up to 5 years. The characteristics of the cohort, we screened 3,696 participants with a CASI from June 2009 to December 2013. 93% of these met high-risk criteria, with 66% reporting 1 or more risk. The prevalence in this group was 29.4%. Of these, 60%, or over 2,000 HIV negatives, entered small blood volume collections. As you can see, our small blood volume visit compliance was quite high at 77 to 87%. 239 participants entered phase 1B, which again was the stutter phase with the reactive Aptima, and we had 95 incident HIV cases for an overall incidence of 3.3. The characteristics of the incident cases are listed here. The mean age was 24. Incidence was highest in Thailand at 4.9 and highest in the first 4 months after enrollment. 59% of patients were female, and regional differences did exist, with Thailand including almost all biologic males, and East Africa, with all infections were among women. Subtypes are listed here in parentheses. On to the busy slide. These data represent our results and show the aggregate viral loads in the first 100 days. 42 patients were included in this analysis. Again, on the x-axis is days from first RNA positive. On the y-axis, viral load in log 10. Day 0 here is the first positive RNA, and these red arrows represent blood collections. So RV217 aimed to capture people in FEBIG 1 or 2, which is this stage. And this study is unique because we were able to show this upslope. The upslope is defined as the rate of change from the last negative to the peak viral load. We found a median interval of last negative to first positive RNA of 4 days. In comparison, if you look here, the days to the EIA turning, third generation EIA turning positive, median was 15 with quite a large range. So we really are catching people before most traditional tests would. Next, this chart also shows the nadir viral load, or the minimum viral load prior to day 60, which is here at 4.3, that occurred at median day 42. I should go back and mention that here, this is the peak viral load, which is 6.7 log 10, and occurred at day 13. Finally, not depicted graphically, the set point viral load was calculated as the average viral load between day 80 and day 360, and was also 4.3. It was difficult to illustrate graphically because it would be out here. Our data did suggest that viral load set point predicted outcome. To further examine correlation of viral load peak and upslope to viral load set point, we ran correlations. To start, we have peak viral load to set point viral load. This is total. So the red dots represent East Africa and the black Thailand. Peak viral load was weakly correlated with viral load set point, and the correlation was stronger in Thailand. Here on the bottom, we have a chart depicting viral load upslope to set point viral load. The viral load upslope did not correlate with the set point viral load. There was a trend for Thailand, which is not shown. Additionally, we have the correlation of viral load nadir to viral load set point. The early viral load nadir and set point viral load were highly correlated, both total and by region. Finally, the correlation of set point viral load to CD4 count outcomes is shown here. At the top, we have CD4 at 1 year to set point viral load, and CD4 at 1 year was inversely correlated with set point viral load. There was little difference by region. The bottom chart showed the last CD4 to the set point viral load, which was inversely correlated with set point viral load as well. So, brief conclusions for this part of the presentation. By prospectively collecting data, we were able to efficiently define the advent of plasma viremia. After the advent of viremia, events in the first 30 days did dictate disease course. The viral load rises and falls over a short interval with the set point established at the conclusion. On to a brief summary of symptoms. So this heat map shows recent medical history. At every visit, we asked a set questionnaire and did not prompt patients on any recent symptoms they had, and conducted a brief physical exam. The darker circles here indicate higher frequency. So as you can see, the total number of findings of any patient was 89% of people in this analysis had any symptom. Peak symptoms occurred prior to the first visit of the viral load peak here, and then continued to decline as you moved away from time. A more detailed look at symptom and physical exam findings is shown here. 56% of all patients reported fever. However, only 4 cases were documented and none were above 38.2 Celsius. Additionally, many patients complained of headaches and feeling of illness or malaise. Physical exam abnormalities were significant for lymphadenopathy and HEENT complaints. Therefore, in summary of our clinical findings, signs and symptoms were common but not severe, and the number of signs and symptoms on any given day were less numerous and of briefer duration than expected. The frequency was clustered prior to peak and at peak. Implications for this: the relative paucity and brevity emphasizes a challenge for physicians who could be evaluating these patients. It's unclear if these patients would have come to see a physician in absence of study participation. So, conclusions and potential implications. Events in acute HIV are determinants of long-term outcome. Reservoirs evolve qualitatively and quantitatively over time and may be more amenable to intervention during the acute HIV phase. Identifying cases of acute HIV may prove difficult. Possible interventions are difficult to evaluate without these special cohort studies that allow us to capture people early in time. And if acute HIV is important to transmissions on a community level, but difficult to identify, what does this mean for the impact of the test and treat philosophy? Elevated viral load period is brief. We do need more data on factors that would influence infectiousness. I'd like to give a special thanks to all our RV217 volunteers, and especially to Merlin Rabb and Leanne Eller from MHRP who helped me assemble this presentation. Thank you.